Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. Today, in continuity with the previous lecture, that is in neurology. Today we'll be discussing on one of the another interesting topic we call as reflexes, and that is deep tendon reflexes. Now, if you can look in this particular, it is a monosynaptic reflex, and the response you get is a contraction of the muscle. So, we have already discussed regarding the introductory part of reflexes. In this, we are going to discuss only regarding deep tendon reflex. So, introduction, different types of deep tendon reflex, method of elicitation, interpretation, and localization. For eliciting the deep tendon reflex, you will require a hammer. There are many different types of hammer. The most common hammer which we utilize is this triangular hammer. Ideally, this is the best. It is a round shape with a long handle. This is a oval shape. This is having only one point, while this is having pointed and one with a broad base. These are the three different types of hammer which are being there. And we have to elicit deep tendon reflex. So whenever we want to elicit the deep tendon reflex, first we have to explain the person what we are going to do. The part to be examined has to be fully exposed, because as far as the deep tendon reflex is concerned, in cranial nerves there is only one jerk, we call it a jaw jerk, where you are eliciting by asking the person to open the oral cavity partially. You put the thumb in the center part of the chin and you give a jerk so that you pull the jaw downwards, and that gives rise to the stretching of the masseter muscle tendon. So fifth cranial nerve, sensory pathway is fifth cranial nerve, center is pons, and motor pathway is also fifth cranial nerve, and that is we call as a jaw jerk. While in upper limb we elicit bicep, tricep and supinator, in lower limb knee and ankle. So these are 5 common reflexes in upper limb and lower limb. Upper limb 3, lower limb 2 reflexes. We have already introduced regarding those reflexes, the part of the tendon reflex. It is a monosynaptic reflex. Now if we come to the root value of the reflexes, bicep is 5-6, supinator is 5-6, while tricep is 7-8, while knee is 2-3-4, lumbar 2-3-4, and ankle is L5-S1, or you say that ankle is S1-S2. So these are the 5 reflexes we elicit in deep tendon reflex in upper limb and lower limb. So fifth cranial nerve is responsible for the jaw jerk. Sensory is fifth, motor is fifth. The muscle involved is masseters, 2 masseter muscle on the 2 sides. Then we elicit the bicep, tricep, supinator in upper limb. By and large, the pectoral reflex is rarely elicited. Finger flexion is also not commonly elicited. So if we go to the bicep, the sensory nerve is musculocutaneous nerve to the bicep muscle. The motor is a nerve supply to the bicep. Root value is 5-6, and the response is flexion at elbow. In tricep, the sensory nerve is radial, motor nerve is radial. The root value is 6-7, and when you tap the tricep tendon, you get extension at elbow. Supinator is again radial, that is motor as well as sensory pathway, while it is a contraction of supinator muscle, or we call brachioradialis, that is C5, C6, and you get a flexion at elbow. We'll be showing you all those positions and how you do it. Elicit will be showing you some of the figure. Pectoral reflex, by and large it is not done, but the nerve involved sensory is lateral and medial pectoral nerve. Motor pathway is same. You're tapping the pectoral muscle. The root value is C5 to T1. C5, C6, C7, C8, T1. And you get adduction of the arm. While in finger flexion, the nerve involved is median nerve, sensory as well as motor. The root value is C6 to T1. And in response, you get a finger flexion and flexion of the thumb. Very rarely these two reflexes are being done. As far as the lower limb is concerned, knee and ankle, these are the two common. In knee, femoral nerve is sensory, motor pathway is also femoral nerve, root value is L2, L3, L4, and response is extension of knee. Ankle, jerk, medial popliteal nerve, root value is L5, S1, and you get plantar flexion at ankle. There are two tests which are, sometimes we do it particularly in case of upper motor neuron palsy, that is Hoffman test. While you flicker the small finger or you flicker the distal part of the phalanx, response is flexion of the finger and thumb. This is called Hoffman test. While Wattenberg test is flexion of the finger against the resistance. You get flexion of finger and thumb, and this is elicited in upper motor neuron palsy. The Hoffman test involves the tapping of the terminal part of the finger or flicking the terminal phalanx of middle or ring finger, and response is flexion of the terminal phalanx and of finger as well as thumb. There is one more name given, finger jerk. You place your middle and index finger across the palmar surface of the proximal phalanxes and you give a tap. You will observe the flexion of the patient's finger. So this is also called as a finger jerk or finger flexion. This is Hoffman reflex. You flick this terminal part of the phalanx, this finger, either middle or a ring finger, and you get flexion of index and thumb. That will be there in case of a hyperreflexia, particularly in case of upper motor neuron damage. The finger, you flick this particular part of the finger, you get flexion of this ring finger, we call index finger and thumb. And when you tap here, this is again a part of method of eliciting the tremor signs. It is labeled as Tromner sign, also called as Wattenberg test. So when you flick this particular, you get flexion of this finger, that is index finger and thumb. And when you can tap here, we call as a forearm, then also you get that. So wrist is dorsiflex, finger are partially flexed, hold partially the extended middle finger and give the flick to the nail of middle finger. Response is flexion and adduction of the thumb with flexion of index finger. Sometimes the flexion of other finger also. This is also called as finger flexion test. You can put the other way around. Yes, this is the Wattenberg test. You ask the person to flex formally. Normally what happens, the thumb goes into abduction and extension. While in pyramidal track, the thumb will go into thumb will go into. So patient supinate his hand slightly, flexing the finger. The examiner pronates his hand and links his similarly flexed finger with the patient's. Both then flexes their finger together against resistance. Normally the thumb will extend through the terminal phalanx, may flex slightly. In pyramidal tract lesion, the thumb adducts and flex strongly. This response. That is called Wartenberg test. So you have got finger flexion test, you have got Hoffman test, you have got Wartenberg test. So in a jaw jerk, the sensory is fifth cranial nerve, motor is also fifth cranial nerve, the muscle involved is masseter. You ask the person to partially open the jaw and then give a sharp jerk over the chin by putting a thumb or finger in between. The response is closure of the jaw due to the contraction of masseter muscle. This is called jaw jerk. In a normal person, it is difficult to elicit. But when the jaw jerk is clearly elicited, we call exaggerated jaw jerk reflex. And this will be seen in case of upper motor neuron, particularly in case of a pseudobulbar palsy. So in normal, the jaw jerk is difficult to elicit. Exaggerated is in bilateral upper motor neuron lesion, which you see mainly in case of a pseudobulbar palsy. While jaw jerk will be absent in case of a trigeminal nerve damage, occasionally in case of a facial palsy, or you are not able to elicit because of wrong methods, and in a case of a non-cooperative person. By and large, it is very difficult to elicit. There is something called as a scapular reflex, where you give a stroke over the skin in the interscapular region. This is scapula. You give a stroke in the interscapular region. The afferent nerve is C4, C5, and center is again a cervical 4 and 5, and efferent is dorsal scapular nerve, and you will get a contraction of the supra and infraspinatus muscle. This is scapular reflex. Occasionally, whenever you want to find out the lesion at the level of C4, C5, you will be eliciting that. The root value here, it is shown C5 to T1, but the main center is C4, C5. So whenever you want to elicit the damage at this level, lower motor neuron, you will be going for that scapular reflexes. In neonates, there are some reflexes. I am not handling this at present. Grasp reflex, which is present in children. Then gabeller tap, sucking reflex, etc. These are primitive reflexes. Sucking reflex, tonic neck reflex, palmar graph reflex. These are some of the primitive reflexes which is elicited in a newborn children and younger children. Now whenever we examine for the upper limb and lower limb reflex, most important part is the position of the limb. Then holding the hammer, then placing the finger over the tendon, and then the amount of force with which you strike. Then what we look for? We look for the contraction of muscle and range of movement at joint. These are the things which we look for. So normally, we have already mentioned pectoral reflex is routinely not done. Finger flexion is, that is Hoffman test, Wartenberg test, or there is also a name given to that test is Rossolimo reflexes. All these tests are only done if you want to elicit the exaggerated reflex in upper motor neuron. So in that case only you elicit these reflexes. Otherwise, by and large, these reflexes are not done. Tonic neck reflex will be in decorticate person. Sucking reflex will be in a newborn children. Grasp reflex is also present in the newborn children. There is one sign called as a Chvostek's sign, which is usually elicited in a tetany. That is by tapping over the facial nerve, you get a phasm of the facial nerve. That is Chvostek's sign, which suggests hypocalcemia. That is tetany. And Trozius sign is a carpopedal spasm during inflation of a BP cuff and maintaining for more than 5 minutes, and you get a spasm of carpopedal spasm. You call that as a Trozius sign. Now when you want to elicit the deep tendon reflex, first explain the person, ensure the person is relaxed. Can be difficult to elicit, especially if person is non-cooperative. Always compare right with left side. If not successful, after 1 or 2 attempts, you can use reinforcement. Do not forget to examine for CLONUS, particularly patellar CLONUS and ankle CLONUS if the reflexes are brisk. And then you can identify whether the reflexes are present, absent, and if they are present, they are normal or exaggerated, or there is a CLONUS. We'll be mentioning all that. So explain the person entirely the method, then put the proper position of the part which you are going to examine. So whichever, suppose you are doing a bicep jerk, so you must be able to see the bicep muscle, elbow, so that upper arm and forearm both should be completely exposed. Put the proper position, and then you have to give a jerk over the tendon. That will be explained much better on a diagram. And when you give a jerk, you have to look at the contraction of the bicep muscle and movement at elbow joint. Same thing will be done for tricep. And when you are eliciting the supinator jerk, you will be looking at the movement at elbow joint, and you will be looking at the contraction of the supinator muscle and brachioradialis muscle. So you will be looking after putting a proper position, and joint where the jerk has to be taken should be completely exposed and proper angle should be maintained. The jerk is given, it is a one single jerk and adequate force, no exaggerated force, no under force. So part which has to be seen, you have to expose completely. We'll see the muscle contraction and movement at joint. Give the jerk to the tendon with proper force and in proper angle, and observe the contraction of muscle and movement at the joint. If jerk is not elicitable, then you can ask the person for reinforcement. When you are eliciting the upper limb, you can ask the person to reinforce by clenching the teeth or closing the fist or closing the eye tightly. And when you are eliciting the lower limb, you can ask the person to grip the two hand fingers with flexion, and always compare right with left, and never give a very hard jerk or jerk with a very hard force. So never give that. And while giving a jerk, there should be a good smooth movement at wrist joint while giving that jerk. So by and large, the Taylor hammer, that is this particular hammer, has to be avoided, because that is the most common hammer which we are using. And this is what we call as a reinforcement method. When you are doing a lower limb jerk, this is the method. While you are eliciting the upper limb jerk, these are the method called Jendresic maneuver, or simple word, reinforcement method. And when you are trying to elicit the lower limb jerk, these are the technique. And while eliciting the upper limb jerk, clenching of the teeth, closing the eye tightly, or fist, close the fist tightly, and then you give the position. Expose the region to be tested, correct position, put the thumb or finger on the tendon and jerk with a sufficient force using wrist and holding the back of the handle, and go back and forth between the right and left side and elicit the jerk, and compare right with left. And while eliciting the reflex, always distract the patient from the reflexes so that you are able to elicit properly. So reinforcement can be done by gripping this method. This is reinforcement. If you want to remember the name, gendrasic maneuver. So while in upper extremity, clenching of the teeth, squeezing the thigh, and while lower extremity, locking the finger and pulling against each other. So these are the technology which you can utilize while reinforcement. You can see here, this is while eliciting the lower limb jerk. When you are eliciting the ankle and knee. And when you are eliciting the upper limb, you have to clench the teeth or clasp the hand together. That will be done in lower limb. While doing in a lower limb, clenching the teeth can be utilized in upper limb as well as lower limb. Deep tendon reflex will be difficult to elicit if you are using a wrong technology, non-cooperative person, if the person is having involuntary movements like tremors, chorea, athetosis, etc. Or if a person is having joint problems in the form of deformities because of ankylosing or fibrosis, or person is having severe arthritis or arthralgia, or muscle problem like myalgia, myopathy or myositis, or if a person is anxious or Parkinsonism, where there is a good amount of involuntary movement, and jerk will be brisk if there is a hypertonia. In old person, because of wasting of the muscle, general debility, malnutrition, hypotonia, reflexes will be difficult to elicit or maybe even absent. In myopathy, myasthenia gravis, due to hypotonia, again it will be difficult to elicit. In hysterical individual, non-cooperative individual, schizophrenia, depression, again difficult to elicit. So all this should be kept in mind while eliciting the deep tendon reflexes. In general, when you mention only one root value for biceps C5, supinator C6, triceps C7. But normally we mention 5-6 for bicep, 5-6 for supinator and 6-7 for tricep. While for knee jerk 2-3-4 and ankle S1, S2. So remember those particular. So what we do in a bicep jerk, we have mentioned here, you flex at elbow at a 90 degree, semi-prone of the forearm, put the thumb or index finger on the bicep tendon and strike with a clinical hammer. And you look at the contraction of bicep muscle and flexion at elbow. In supinator, or we call as a brachioradialis reflex, you have to flex at elbow, semi-prone the forearm, put the thumb or index finger or on brachioradialis tendon just little above the styloid process of radius and strike with the clinical hammer. You get contraction at elbow and supination of forearm. In tricep, you put again the same position, but now on the extensor surface of olecranon process. Elbow is flexed, raise the forearm across the subject chest and tap the tricep tendon with clinical hammer. And you will get a contraction of the tricep muscle. You will get extension at elbow and contraction of tricep muscle. Root value of bicep and supinator is 5-6, while tricep is 6-7. Knee jerk, either in lying down position or in sitting position. Best way is in a lying down position. You put the knee joint at 90 degree. So when you put the knee joint at 90 degree, you are also flexing at the hip joint. And after well relaxation, you tap over the patellar tendon. And when you tap over the patellar tendon, you get extension at knee and contraction of quadricep muscles. And this is L2, L3, L4. While ankle jerk, you can elicit in a sitting posture, you can elicit in a supine posture. In again supine posture, you flex at knee and slightly you do dorsiflexion at ankle. And in that position, you give a tap over the tendo achilli and you look for the contraction of quadriceps, gastrocnemius and soleus muscle, and you get a plantar flexion of Ankle, plantar flexion due to contraction of gastrocnemius muscle, calf muscle, and you get plantar flexion at ankle. Root value is S1, S2. Now we'll be showing you all different position. See here, this is at a right angle, thumb is kept and you are giving a sharp tap. This is right angle, you are giving a tap on the tricep. So this is tricep reflex. And you are giving a jerk over this. This is a lower end of the radius. We call styloid process of radius. Just above that, you give a tap. You give a tap. You can give direct tap or you can put a thumb and then give a tap. Here on tricep, direct tap is given. By and large, while eliciting a bicep, you put your thumb or finger over the bicep tendon and then you give a jerk. There are many different methods. You can see here, the thumb is kept and then jerk is given. Here again, thumb is kept, fingers are kept and you are giving a jerk. By and large, this hammer is avoided. You use this clinical hammer. And we have already mentioned the root value of bicep 5, 6. And response is contraction of bicep muscle. So you look at the contraction and flexion at elbow. Again, you can see this. This is in supine posture. In supine posture, you are putting a thumb on the bicep tendon. Elbow is by and large at nearly right angle. And then you are giving a jerk. You can utilize whatever position you want. But you have to put the elbow at 90 degree. And thumb over the bicep tendon and then you give a sharp jerk. And look at the contraction of bicep tendon and flexion at elbow. You can see multiple different ways of position. Best way is ideally in a supine posture. Best way. But you can elicit also in a sitting posture. This is tricep. You can see this is in a sitting posture. This is in a sitting posture. Elbow is at right angle. You are supporting the elbow part. You look at the contraction of tricep muscle and extension at elbow. Again here, this is in a supine posture. This is the best technology. You are giving a tap over the tricep tendon. You look at the contraction of tricep muscle and flexion, extension at elbow. That will be tricep. This is again tricep. You can see that. Best is in a supine posture. Best way is in a supine posture. Yes, you can elicit in a sitting posture also. Two-way, either by putting a and supporting the hand like this, or this is the another position. These are all the different positions. You can see. Best way is in supine posture. This is sitting posture. This is again supine posture. This is again sitting posture. This is again in sitting, but holding the hand in this pattern. This may be little difficult, but again, this is one of the technology. While supinator, you can give a direct tap at the tendon of supinator, or you put a finger and over the finger, you can see that this is the best way. This is in sitting posture. This is in supine posture. Supine posture is always better. You are keeping at a 90 degree and you are putting a finger over the supinator tendon and you are giving a jerk. Again, this is a sitting posture. We call brachioradialis. So you put your finger over the brachioradialis just above the styloid process and you give a tap. This is supine. This is sitting posture. This is again sitting posture. This is again sitting posture. This is sitting posture. This is again sitting posture. Whichever you feel comfortable. But still I'll say that it is better in a supine posture because person will be well relaxed. This is finger flexion. You are holding the palmar surface of the person and you tap from the bottom and you are putting your finger close to the finger of the person in whom you are examining. So finger on index and middle finger, finger of your left hand and curve those fingers slightly. Now when you strike your finger, we strike our finger, you get flexion of the finger of the person. This can be normal, but it will be exaggerated in a person who has got upper motor neuron. We call finger flexion test. As far as the knee jerk is concerned, we have also shown you Wattenberg test and Hoffman test. In a knee jerk, you can put them and allow them to in a 45-degree angle at knee, and then you give a jerk at patellar tendon, and in a supine posture, you can give a jerk over the tendo achilles. And another way is a sitting posture. But while sitting posture, see that you don't get this phenomena. So this is in a supine posture, you are putting it at 90 degree. This is at a 90 degree. And you are giving a sharp jerk on patellar tendon, and you can easily. But this portion, you are observing the contraction of the quadriceps should be completely exposed, so that you can look at the contraction and you can look at the extension at knee. So you give a sharp jerk at patellar tendon. You have to give at the patellar tendon. At patellar tendon and look at the contraction. This portion should be exposed so that you can observe the contraction of quadriceps. This is in supine posture. Also, same jerk can be elicited in sitting posture. This is a very nice way. You keep it at nearly 90 degree. Nearly 90 degree. Or you can give a support to the limb which you are checking. So in a lying down posture, it is always better. You give a support and then you give a jerk to the patellar tendon. So that will be the best way. Another way is hanging down. This is another way. But person should be well relaxed. So this will be another technique. By putting the leg into hanging position in a sitting posture, and then you give a sharp jerk at the patella. Ankle, you can give it, put it at the 90-degree angle, put it on the other limb, little plantar dorsiflexion, and then give a sharp jerk on the tendo achilles. You will get a plantar flexion of foot at ankle and contraction of, we call calf muscle. That will be the way. That will be the ideal way. And I will be uploading the one video lecture including multiple clips showing you how exactly it is being elicited. And this is in a hanging position. You can try to, this is little difficult, but as far as possible, don't try to elicit the ankle jerk in this position. It is best in supine posture. Very, very difficult, but still you can. This is absolutely very, very difficult, but best in supine position. Either you can put the ankle in this and elicit, or this is much better. You put it at 90 degree, little dorsiflex, and then give a jerk at tendo achilles. That is much better. Now the most important part. If jerk is absent, we put that as a 0. We put that as a 0. And if it is normal, then we put them into 3 division. 3 division. Absolutely normal, we call 2 plus. Little reduced movement, we call hyporeflexia. Reflex is present, but the movement is diminished. So, and person may require reinforcement to elicit the jerk. And if jerk is elicited but with minimal tap, we call that as a brisk. And when you get a brisk reflex plus you can elicit the clonus, then it is divided into 2. Some people say with clonus and sustained clonus, we call 5 plus. And when brisk reflex without clonus, then it is called 4. Whichever way, it is better way, normal, brisk, sustained clonus, non-sustained clonus. And less than normal, we call as hyporeflexia. And when it is totally absent, we call areflexia. So those are better words. So usually we use those words. And then you can interpret and put a diagrammatic way. This is bicep, this is supinator. You can put tricep here. This is abdominal reflex, this is knee jerk, this is ankle, and then you can put regarding plantar, extensor or flexor, depending upon that. Now most important part, how you interpret. If reflexes is normal, means we put grade 2, we call normal, and it has to be bilateral equal. If reflex is totally absent, we call grade 0 or we call areflexia, which will be classical in case of a lower motor neuron. And if reflex is brisk, with or without clonus, brisk, non-sustained clonus 4, sustained clonus 5. So if it is brisk and clonus is elicitable, it is 4 and 5. If clonus is sustained, 5. Non-sustained, 4. Only brisk reflexes, 3. So that indicates upper motor neuron palsy. Very, very simple. Now I'll explain the other way around. Suppose if you get the damage at the level of lumbar 2. So at the level of lumbar 2, it will be lower motor neuron. Above lumbar 2 segment, reflexes will be normal. And below the level, you will have upper motor neuron type, what we call as a brisk reflexes. So in a case of a hemiplegia, on the side of damage, it will be upper motor neuron. So bicep, tricep, supinator, knee and ankle, all will be brisk in case of a hemiplegia if there is a damage above brainstem or even above spinal cord. That will be classical, unilateral. But say in both lower limb, knee jerk and ankle jerk is exaggerated, but upper limb reflexes are normal. So lesion has to be above lumbar 2 segment and below C8 segment. So if I get the damage at the thoracic level, I will have typical paraplegia with both lower limb jerks exaggerated. Means brisk and clonus may be present. But say I get a damage at the level of lumbar 2, I will have ankle jerk absent. Sorry, knee jerk absent because knee jerk is concerned with lumbar 2, lumbar 3 and lumbar 4. So knee jerk will be absent at that level on that side, and ankle jerk will be upper motor neuron. So that will be exaggerated or brisk, or we call clonus will be elicited in ankle, but in knee it will be grade 0. So this will be the peculiar distribution. So this is the way you try to elicit the ankle jerk. We have got a nice clip. We'll be showing you that. So clonus, if it is elicitable, it is in favor of upper motor neuron. We say that hypertonia ending into ankle clonus. And you can elicit also patellar clonus. So if reflexes is absent, it is a lower motor neuron because of damage to the motor root or sensory root or spinal cord root center. So whichever reflex is there, if at the spinal cord level, if there is a damage, it will be lower motor neuron palsy, or if you have got a damage to the motor pathway or sensory pathway, that reflex will be absent because that is lower motor neuron. Or it will be difficult to elicit. We have already mentioned what are the conditions where it will be difficult to elicit. You have to always compare with the opposite side because bilaterally it should be equal and elicitable. But if reflex is brisk, then it is because of upper motor neuron palsy. Also, it will be exaggerated or brisk in case of any condition which increases the tone. Classical example in anxiety or even in case of an extrapyramidal damage. So in that case also the reflexes may be brisk. But in a upper motor neuron palsy, which can be unilateral or bilateral. Unilateral classical example, hemiplegia. Bicep, tricep, supinator, knee and ankle all will be exaggerated on the side of the damage. While in case of a both lower limb, that is paraplegia, knee jerk and ankle jerk will be brisk and exaggerated. And ankle clonus and knee clonus, or we call patellar clonus, will be also elicitable. but bicep, tricep and supinator will be normal. But if you come across quadriplegia, that is if there is a lesion above C4 level, then you will have a quadriplegia. So all reflexes, both in upper limb and lower limb, will be exaggerated, and you will have an ankle clonus and patellar clonus elicitable. Jaw jerk will be normal. But if jaw jerk is also exaggerated and all upper limb and lower limb jerks are also exaggerated, it will happen in a pseudobulbar palsy. Means the bilateral upper motor neuron palsy above brainstem. In that condition, it will be pseudobulbar palsy. So you will have an absent jerk in peripheral neuritis, posterior horn damage, disc protrusion, poliomyelitis, motor neuron disease, Guillain-Barré syndrome. Also, it will be very difficult to elicit in case of myopathy, myasthenia gravis, etc. Those are muscular disorders. So, exaggerated jerk in upper motor neuron disease below the level of damage. It will be also increase, or you will have a brisk jerk in tetanus, hysterical, anxiety, young individual, fright, strychnine poisoning, thyrotoxicosis. So these are non-neurological conditions. These are non-neurological conditions. And also we are able to elicit in tetany, Chvostek's sign and Trozius sign. While absent jerk will be in a lower motor neuron whenever there is a damage at the level of damage in spinal cord or in the brainstem. Also in an acute spinal shock and neurogenic shock, all tendon reflexes will be absent temporarily, and later on they will be brisk and exaggerated once the tone increases. In normal individual, if your technology is wrong, or in an old person or person who has got a flabby muscles, the jerk will be difficult to elicit. In acute stage of upper motor neuron palsy, so acute neurological insult will also have absent jerk initially. Later on, it will be exaggerated due to increased tone in the muscle. In hypothyroidism, myasthenia gravis, myopathy, painful muscular conditions, and also in case of we call as joint deformities or arthritis, arthralgia, the reflexes will be very difficult to elicit, and good number of time in myopathy, myasthenia gravis, it will be diminished or absent. So this should be remembered. Exaggerated in a non-neurological condition like thyrotoxicosis, anxiety, tetanus, tetany. But in upper motor neuron, it is because of a neurological damage. Below the level of damage, it will be upper motor neuron. And diminished or absent in lower motor neuron at the level of damage. And below the level of damage, upper motor neuron. Above the level of damage, if reflex arc is preserved, it will be normal. And if a person is in a deep coma, also you may not be able to elicit the reflexes. In cerebellar lesion, you will have a slow contraction and slow relaxation. We call pendular reflex. This is one difficult to elicit, but if it is elicitable, it suggests cerebellar lesions. So hyporeflexia at the level, radiculopathy, mononeuropathy, polyneuropathy, acute stroke, acute spinal cord injury. And generalized hyporeflexia in case of a hypercalcemia, hypermagnesemia, hypothyroidism, deep coma, and GBS will be generalized, bilateral symmetrical generalized. While here at the level of damage, while hyperreflexia at the level of damage because of early stage of amyotrophic lateral sclerosis or delayed finding in spinal cord injury below the level of damage, and in a case of a hemiplegia, delayed findings, you will have hyperreflexia because of increased tone in the muscle. But generalized hyperreflexia, classical in case of tetany, hypomagnesemia, thyrotoxicosis, serotonin syndrome, eclampsia, late stage of amyotrophic lateral sclerosis. These are some of the conditions, you should keep it in mind. But by and large, we come across, we call as a stroke and paraplegia. So in upper motor neuron palsy, we know that the person in upper motor neuron, below the level of lesion, you will have a involvement of the muscle, the power will be diminished, the muscle will show wasting in a late stage, tone will be hypertonia, reflexes will be hyperreflexia, BRISK, and CLONUS may be elicitable. And if you see a superficial reflexes, that is abdominal reflex, cremastic reflex, anal reflex will be lost. And in a wasted muscle, you will not be able to see fasciculation frequently. But in a lower motor neuron, at the level of damage, you will have complete hypotonia, hyporeflexia, reflex is absent, mark wasting, and in a wasted muscle, you will see fasciculation. Superficial reflex at the level of damage will be lost. Plantar reflex will be normal in lower motor neuron, and if there is a damage at the level of alpha S1, plantar reflex will be absent. Otherwise, if the damage is below the level of alpha S1, plantar reflex will be preserved. But in case of upper motor neuron, on the side of the damage, plantar reflex will be extensor, or we call Babinski's sign will be positive. This will be combined picture of upper motor neuron, and this is combined picture of lower motor neuron. So at the level of damage, lower motor neuron, deep tendon reflex and superficial reflex both will be absent on the side of the damage. Below the level of the damage, due to damage to pyramidal tract, you will have an increased tone in the muscle. Because of increased tone in the muscle, reflexes will be brisk and CLONUS will be elicitable on the side of the pyramidal tract damage. Superficial reflex will be absent on the side of the damage, particularly abdominal reflex, cremastic reflex, anal reflex. And above the level of the damage, on the same side, all reflexes will be normal, and on opposite side, all reflexes are normal at the level, above the level, and below the level. This is classical finding in deep tendon reflex, as well as I have combined with superficial reflexes. So interpretation is very clear. Unilateral loss of deep tendon reflex at the level of damage, lower motor neuron. Bilateral jerks are absent. It will be bilateral lower motor neuron palsy, classical in case of Guillain-Barré, poliomyelitis, motor neuron disease, myopathy, general debility, severe hypoproteinemia, old individual, etc. Unilateral or bilateral jerks are absent for some period of time during acute neurogenic insult, and later on, because of increased tone in the muscle, they will be brisk. Unilateral or bilateral jerk are brisk in upper motor neuron, particularly bilateral in case of a pseudobulbar palsy, and unilateral in case of a hemiplegia. Deep tendon reflex in normal person, it is normal. It will be absent in lower motor neuron. Unilateral brisk, that is CLONUS, is present in a hemiplegia. Bilateral brisk, pseudobulbar palsy, or anxiety, or thyrotoxicosis, etc. Brisk at the level in case of a spinal cord damage, below the level of the damage, at the level absent. Knee jerk will show you hang up reflex in case of myxedema, that is slow contraction and slow relaxation, while you will get a pendular jerk in a case of a cerebellar lesions. In myotonica congenita, contraction of the muscle will remain for a very long period, and it can be seen very clearly in the tongue also. That is, you just tap over the tongue, you will get contraction, and there will be very, very slow relaxation. That is myotonica congenita. organic reflexes, or we call it the visceral reflexes, particularly swallowing reflex, anal reflex, or maturation reflex, we are not handling at present. Doll's eye movement will be what we call as a for brainstem lesions. They are also called as oculocephalic reflexes. You have to elevate the eyebrow of both eye and rotate the head. When you rotate the head to the right side, eyeball will move to the left side. And when you rotate the head to the right side, eyeball will move towards the left side. So when you rotate the head this side, eyeball will move to the opposite side, that is left side. And when you move the head towards the left side, eyeball will rotate towards the right side. And when you flex the neck, eyeball will go up. When you extend the head, eyeball will roll down. If these movements are absent, we call doll's eye movement are absent. And that will be in case of a damage at the level of pons. So if doll's eye movement is preserved, it means pons is intact. Doll's eye movement absent, it means pons is damaged. One important clue. Kernick's sign, Brudzinski's sign is useful for demonstrating irritation of meninges, and we call that as a meningeal signs. So they will be present in meningeal irritation like subarachnoid hemorrhage, meningitis, encephalitis, and among meningitis bacterial and viral. It will be present, and sometimes it is also present in case of meningism, which is because of inflammatory response and irritation of meninges. There is a peculiar posture which you will see in a case of a damage to the extensive damage to the cerebral cortex because of raised intracranial pressure or cerebral edema, etc. We call it a decorticate posture, in which the upper limb are flexed. There is a flexion at wrist. So leg and feet are extended with plantar flexion of foot and arm and flexion at elbow. This is called decorticate posture. Decorticate posture. Extension at knee, internal rotation. And here you will have flexion at elbow and flexion at wrist and flexion of the fingers. In decerebrate posture, arms are extended, externally rotated, and lower limb are also in extension and external rotation. While in a case of a complete flaccid, all limb tone is lost. So I end my lecture here. These are all the importance of eliciting the deep tendon reflex. And in the next video, I'll be putting the small clips which shows you CLONUS, Hoffman sign, finger flexion sign, and also how the ankle, knee jerk, bicep, triceps are elicited. So thank you very much for taking out time. I know that your time is valuable, and I appreciate that you have spent some of the time with me. If you like this particular lecture, don't forget to press button like, subscribe, and you can share with your friends. See you in next lecture.